Hi everyone, I'm Lindsey Albenberg, a pediatric gastroenterologist at Children's Hospital of Philadelphia. I am going to be sharing with you my thoughts on why diet therapies for IBD. So as you are all aware, IBD is becoming a global epidemic. The incidence of IBD rose steadily in the 20th century in the Western world. IBD was relatively rare in developing nations, but over the past few decades, newly industrialized countries have documented the emergence of IBD, including countries in Asia, South America, and the Middle East. So with this rapid rise in IBD, what does the future hold? So we know that IBD is a global disease. About 5 million people are affected worldwide. The prevalence of IBD in the Western world is 0.5%, and the rate in the rise of incidence of IBD has been steep, particularly in newly industrialized countries, but also in adolescents in industrialized countries. We also know that the number of patients with IBD in newly industrialized countries might approximate that in the Western world by 2025, owing to rising prevalence and rapidly growing populations. And so clearly this will place significant strain on healthcare systems, and we need better and more comprehensive therapies fast. So this correlation with industrialization suggests that these are largely environmental diseases. So they are not solely driven by genetics in the vast majority of individuals. But thus far, our therapeutic approach really has focused on immunosuppressive medications, but increasingly, and I think rightly so, attention is being placed on the environment, such as the gut microbiome and diet. And from a diet perspective, the hypothesis is that perhaps diet-triggered changes in the intestinal microbiome can cause a pro-inflammatory state that precedes the development of IBD. So why do we need dietary therapies for IBD? So I think there are several reasons. First, science tells us that something in the lumen of the gut is driving inflammation. Additionally, our patients want to know what they should eat, and the information on the internet is not consistent and it's not evidence-based most of the time. We also know that our patients are already changing their diets, and so we need to be supporting them, and that involves understanding the evidence. We also know that even our best therapies, as we'll discuss, are not effective in all patients, and they are associated with risks. So let's talk about the science first. So we've known for 20 years that diversion of the fecal stream is a treatment for some patients with Crohn's disease. And so for refractory colonic Crohn's disease, for example, a diversion ileostomy can be therapeutic. Most commonly, a loop stoma is created, which allows access to the bowel distal to the stoma. So this is a study that was published in 1998, and it was a study where 3 patients with Crohn's disease who had undergone an ileocolonic resection with ileocolonic anastomosis and temporary protective proximal loop ileostomy were enrolled. What they did is that following surgery, they took biopsies of the ileum once it had healed. And so you can see that this is normal in figure A here, normal ileal histology. So then what they did is for 3 straight days, they collected these individuals' ileal contents, so their ostomy contents, and they reinfused them into the loop stoma, and so that the ileal contents were in contact with the ileum once again. And what you can see in panel B is that after just 8 days of infusion of ileal contents, inflammation started to return. And so you can see in the panel on the right that there is a significant increase in the histologic inflammation index in all 3 individuals. We know that the major component of our ileal contents includes partially digested food as well as digestive secretions. And so I think this really raises the question, is something in our diet driving the inflammatory process? So can traditional epidemiology lend any insight? So this study looked to understand the early life environmental exposures on disease phenotype in children who were diagnosed with inflammatory bowel disease. And so the specific question here was really surrounding infants' first exposure to food. And so this study gave us evidence that breastfeeding may have an impact on disease behavior. So what this study did is they looked at children who were enrolled into the risk study, which is a pediatric inflammatory bowel disease inception cohort. And in this study, history of breastfeeding was inversely associated with the development of complicated phenotypes such as stricturing and penetrating disease. And so again, I think this raises the question, can diet in early in life, and particularly our earliest environmental exposures affect not only the disease incidence, but also the disease behavior. So moving past infant feeding, there are additional epidemiologic associations between diet and the development of IBD. So this was a systematic review to assess dietary intake pre-IBD diagnosis and the risk of developing IBD. And in this study, it was identified that high dietary intakes of total fats, polyunsaturated fatty acids, omega-6 fatty acids, and meat were associated with an increased risk of Crohn's disease and ulcerative colitis. High fiber and fruit intakes were associated with a decreased Crohn's disease risk, and high vegetable intake was associated with a decreased ulcerative colitis risk. And then this is a more recently published study, which I think is very interesting, by Ashwin Ananthakrishnan, where they looked at food frequency questionnaires, which were collected in 3 large observational cohort studies enrolling healthy adults. And so this included the nurses' health studies. And they calculated something called an EDIP score, or an empiric dietary inflammatory pattern score, which is essentially a weighted sum of 18 food groups. And the higher an individual sum, the more pro-inflammatory the diet. And this score has previously been correlated with serum inflammatory markers, including CRP, IL-6, and TNF-alpha. In this study, they had many patients enrolled or that they were evaluating, with over 4 million person years of follow-up. At the end of the study periods, 328 individuals developed Crohn's disease and 428 individuals developed ulcerative colitis. And what they found was that for the individuals who were in the highest quartile of EDIP score, there was a 51% increased risk of developing Crohn's disease. In this study, there were no associations of dietary inflammatory potential with ulcerative colitis, but I do think that the Crohn's disease data are quite interesting. So what can we learn from epidemiologic data? It seems that what and potentially when you eat potentially influences a person's risk of developing IBD. And so this is the way that we have been viewing things for quite some time now. We recognize these epidemiologic associations between diet and the development of IBD. We also know that in IBD patients, there is an abnormal composition of gut microbes, and multiple studies have demonstrated that diet plays a really key role in determining the composition of the gut microbiota. And so it's logical to think that diet may be involved in the development of IBD, and that diet may be a potential therapy. So dietary therapy makes sense. Moving beyond epidemiology, I think we're getting closer to understanding mechanism to some degree. I think we still have a ways to go, but I also think that there is reason to believe that there is potentially something bad in our usual diet that's involved in the pathogenesis or the perpetuation of IBD through its effects on the gut microbiome. Oops. The panel on the left comes from a recent review, which I think nicely summarizes foods and nutrients that have been shown primarily in animal models to have an impact on gut barrier function. Some food components that increase gut permeability will be familiar, like fructose and dietary emulsifiers, which are both ubiquitous in processed foods and highly prevalent in a Western diet. And I don't think we can say that these potentially pro-inflammatory food components are uniformly bad, and we certainly cannot say that they cause IBD, but I think we really cannot ignore the fact that our food supply is fundamentally different than it used to be when IBD was rare or did not exist at all. And so I think this really raises the question, and I borrowed this nice figure from Ari Levine, can the Western diet be the environmental trigger for IBD through effects on host barrier and immunity and the microbiome? So next we'll talk about the fact that our patients really want to know what they should be eating, and we know that they are already changing their diets. So we know that diet is important to our IBD patients. One of the first questions that patients ask us is, what should I eat? And many patients follow, in essence, their own exclusion diet based on the perception that certain foods either worsen or improve symptoms. This study comes from IBD Partners, which is an ongoing internet-based cohort study of patients with IBD. And in this study, patients in this cohort were surveyed with open-ended questions to elicit responses about food items that they believed either ameliorated or exacerbated their IBD symptoms. So here, CD is Crohn's disease, we have ulcerative colitis, CDO is Crohn's disease with an ostomy, and then UCP is ulcerative colitis with an ileal pouch. In this study, yogurt and rice, interestingly, were found to improve symptoms within all groups of patients, while bananas were found to improve symptoms in patients with total colectomy and ileal pouch. Foods perceived to worsen symptoms were overall consistent among the groups, and not surprisingly, patients tended to avoid foods that they reported as worsening their symptoms. And it's important to recognize here that feeling well by eating a certain way or having an exacerbation of symptoms related to eating certain foods may not always have a direct correlation with the amount of inflammation. And then lastly, we'll talk about the fact that even our best therapies are not effective in all patients, and they are associated with risks. And also, I think particularly relevant to our population is that patients with IBD diagnosed in childhood will have years of disease to come and many potential exposures that we need to think about in the treatment of these patients. So if you look at our biologic and small molecule therapies that have been developed in the last 2 decades and the randomized controlled trials that have brought them to market, you will see, sort of when summarizing all of these studies, you see clinical response rates to induction treatment in the 50 to 60% range. We also see about 15% endoscopic and histologic remission. And we know that our patients will lose response to therapy at a rate of approximately 15% per year. We also know that when it comes to Crohn's disease, nearly 100% of patients will have recurrence of their disease at some point after the therapy has been discontinued. And in the pediatric world, our trials, for example, the REACH trial looking at infliximab in Crohn's disease, our trials have overall yielded somewhat better results in terms of response and remission rates than the adult trials, but we still have significant room for improvement. Meta-analyses and randomized controlled trials in adult patients have overall concluded that in the biologic era, there has been a reduction in surgical rates in Crohn's disease. However, again, I think that there is clearly room for improvement and really raises the question, can treating to target further decrease the number of surgeries? And treating to target, one could imagine, could include adding on dietary therapies to standard therapies, or in some patients where it's deemed to be appropriate, utilizing dietary therapies first line and as a solo therapy. And then there are safety concerns such as infections and malignancy. So this table shows the absolute risk of cancer in patients with IBD exposed to immunosuppressive therapy versus those not exposed to immunosuppressive therapy. And I have just a panel here that shows many of the safety concerns associated with the immunomodulators and the biologics, which most of you will be familiar with. So I won't go through these individually, but it's clear that we are seeing more and more patients and parents in particular demanding dietary therapies for their children because they are unwilling to accept these rare but very real risks. And then finally, I just want to end with a thought, which is really stressing the importance of this preclinical phase. So this is when patients can have inflammation for months or even years prior to their diagnosis, and the importance of studying biomarkers in high-risk populations to identify these individuals. And this is clearly a place where you could envision, one could envision diet being utilized in the future as a way to prevent the development of the disease in high-risk individuals. So more to come, I think, on this in the future. So why do we need nutrition therapy in IBD? Because it makes sense, because I've shown you that our medications can only do so much and have limited efficacy. We know that medications are not a cure. Medications have rare but very real safety concerns. And we know that children with IBD will have a lifetime of treatment ahead of them. Thank you so much.